So today's presentation is covering oxygenation, which is the hemostasis of oxygen intake, carbon dioxide elimination, and distribution of oxygen to all body tissues through the coordination efforts of the intact respiratory, hematologic, and circulatory systems. At the end of this unit, the student will be able to determine factors that can lead to alterations in oxygenation for infants and children. Identify an infant or child in respiratory distress or failure. Nursing management and collaborative care of the patient and fetus with impaired oxygenation. Integral relationship between oxygen and perfusion. And current evidence-based practices related to oxygen impairment. Additionally, you'll be able to analyze the pathophysiology of meconium aspiration syndrome and its clinical signs. Okay, here's your exemplars and your readings. So the ones on the left are for this class. On the right, this is what you need to review from 227. Okay, so we're talking about baby today. So in utero, your gas exchange occurs via the placenta. Okay, the lungs are not working for gas exchange. Instead, we have increased amount of red blood cells that get oxygen to the vital organs. The lungs will mimic normal respiratory movement in preparation for transition. So in other words, baby practices breathing by swallowing amniotic fluid. All right, during labor and delivery. All right, so normal labor causes hypercapnia, which is the excessive carbon dioxide in the bloodstream that's caused by inadequate respiration. Okay, besides hypercapnia, we have hypoxia and acidosis. Okay. So respiratory acidosis occurs when the lungs can't remove enough carbon dioxide. Okay, all three of these things stimulate respirations. So if you remember, in the top picture there, during labor, all flow to the baby is cut off at the peak of a contraction. Okay, so that means there's absolutely no blood flow to the uterus, which means no oxygenation. Okay, then in the bottom left, while baby is moving through that birth canal, there is no air supply. Okay, so both perfusion being cut off during contractions and going through the birth canal both cause mild asphyxia for the baby. Okay, this stimulates the respiratory center of the brain. Now, when the chest is compressed and then the pressure is released, the baby inhales air into the lungs. This mechanical squeeze during a vaginal birth allows the amniotic fluid in the lungs to be expelled. The fluid goes out through the pulmonary capillaries and the lymphatic system. Okay, so at birth, crying promotes positive pressure, air in the lungs, and alveoli expansion. Okay, there's a gasping reflex from noise, light, cooler temperatures, increased CO2, decreased O2, and handling. There's a significant decrease in the environmental temperature after birth. Okay, this stimulates the nerve endings of the skin, and the newborn responds with rhythmic respiration. Okay, so here it is. Our baby cries. Let's see. We are surrounded by noise, lights, the cold temperature compared to in utero, and our baby is being handled with physical touch. All of these processes allow our baby to normalize those rhythmic respirations. All right. This is looking at the respiratory assessment of a newborn. All right. So this is your reminder of, respiratory rate, breath sounds, O2 sats, respiratory pattern, chest expansion, and mucous membranes. Make sure that you know these so that you can tell in a scenario if the baby is experiencing normal things or abnormal. Okay, as we continue on, so babies have apnea, okay? So they have little short periods where they physically stop breathing, okay? If the apnea lasts less than 5 seconds, it's totally okay and it's totally normal, okay? Your periodic apnea can last 5 to 10 seconds, and it's okay if we stimulate the baby and the respiratory pattern converts back to normal, and there's absolutely no color or heart rate changes. Okay? Now, apnea lasting longer than 20 seconds is abnormal. Okay? If you look, you have signs of respiratory distress listed. Okay, some general signs here. Retractions, grunting, tachypnea at rest, nasal flaring, labored respirations, and a very late sign would be cyanosis. All right, now, so your first condition, hopefully you talked about these in your former class, but TTN, which is transient tachypnea of the newborn, and RDS, or respiratory distress syndrome. All right, so what's the difference? TTN is specifically due to extra fluid that's hanging out in the lungs. Okay, so we haven't cleared all of our fluid. Okay, so if you remember what we just talked about, during that vaginal birth, you get that chest compression, amniotic fluid is expelled from the lungs. But your C-section babies do not have this advantage. Okay, they completely miss that mechanical squeeze, and so it is quite normal for them to still have fluid in the lungs and experience TTN. Okay, so TTN, they just need time to transition. Transient means it goes away on its own. You can see signs of distress shortly after birth. Should resolve within 24 to 72 hours. Okay, some risk factors for TTN are maternal diabetes, asthma, a male baby, macrosomia, and C-section delivery. All right, the symptoms you might see: expiratory grunting, nasal flaring, mild cyanosis, tachypnea by 6 hours of age, and mild respiratory and metabolic acidosis. Okay, we are going to diagnose TTN with multiple x-rays, and really it's supportive care. Okay, so in some cases these babies need supplemental oxygenation. We might give them IV fluid and electrolytes. If they are breathing quickly, so that's over 60, then we will not feed them orally. So they may need a different kind of feeding. Okay, now your RDS babies, the difference is we have an inadequate production of pulmonary surfactant. Okay, so remember that we need surfactant to keep the alveoli expanded. Without the surfactant, they collapse and baby experiences respiratory distress. Okay? Peak production of surfactant is 35 weeks gestation. So anything born before that is definitely going to have some issues. Okay? So characteristics of RDS are going to be cyanosis, pallor or mottling, tachypnea, grunting, nasal flaring, retractions, apnea, labored respirations. And the symptoms are either shown at birth or within a few hours. Risk factors for RDS include preterm birth, perinatal asphyxia, neonatal sepsis, a C-section, a male baby, and maternal diabetes. Okay, so once again, we're going to diagnose RDS with chest x-rays. And we want to make sure that we rule out any underlying causes like infection or sepsis in this case. Okay. Now we may want to try to prevent RDS if we know we're going to have a preterm baby. We know also that the respiratory system develops last. So we may administer glucocorticoids to the mom if birth is imminent. After birth, if it's a preterm baby, we may give some surfactant replacement, and we'll talk about that later. And then there's many different modes of oxygenation, which we are going to talk about in just a second. All right, so this takes us to our treatment with our oxygen modalities. All right, so we do have hood therapy. This is when oxygen goes through a hood and when a mechanical vent is not required. So you can see to the back of the hood on the left side, there's a little tube sticking through it. Okay, and so this really concentrates that oxygen on the babies to breathe in. Okay. We have nasal cannula to the right. Usually we're going to give a low flow continuous oxygen. Okay. On the bottom, let's see here, bottom left. So on the far left, you've got nasal IMV. So it's a ventilator, but it's through the nose instead of a tube down the throat. Then next to that one, you got the mask here. This is nasal CPAP, all right, which is continuous positive airway pressure. It infuses oxygen at a preset pressure by means of a face mask or a nasal cannula or even an ET tube. Okay. Now, because we're giving so much air to the baby here, we want to make sure that the baby has an orogastric tube placed so that it will decompress the stomach. Okay. However, risks of CPAP is that it can cause vascular shunting into the pulmonary beds, leading to persistent pulmonary hypertension and severe RDS. Okay. Far right on the bottom is our sweet little baby with mechanical ventilation. So this baby is intubated. And again, it is set to provide a predetermined amount of oxygen during spontaneous respirations, but also provides mechanical ventilation in the absence of spontaneous respirations. Okay. We may also administer dexamethasone to these babies to prevent chronic lung disease. All right, continuing on with our respiratory treatment, we have nitric oxide therapy. This is inhaled nitric oxide gas, causing a potent, sustained pulmonary vasodilation, and it is safe. It binds with hemoglobin in the red blood cells, and it's inactivated after metabolism. Okay, down that bottom left, you'll see what we call an oscillator, which is high frequency ventilation. Okay, so we're going to provide high frequency ventilation by providing smaller amounts of oxygen at significantly more rapid rate. Okay. And last but not least, we have our ECMO. Okay, so ECMO uses cardiopulmonary bypass to oxygenate the blood outside the body through a membrane oxygenator or an artificial lung. Okay, so how can we assist our baby to maintain adequate oxygenation? Okay, and we're talking about our normal newborns and preventing respiratory distress, or our babies that already have problems to keep them from getting worse. All right, so one of the things we can do is maintain their thermoregulation. So you'll see you've got two pictures for that one. You have one where the baby's under the radiant heat warmer, and then we have a baby in an isolette. Okay, both of these interventions are appropriate. It's your teeny tiny babies that are mostly going to go in the isolette, but as we keep them warm, the work of breathing will actually decrease. All right, then we have nutrition. So of course we need to maintain our nutrition. We're going to have alternative feeding methods if our baby is tachypnic. Okay, so respirations over 60, we are not going to bottle or breastfeed. So more than likely they're going to have some kind of a feeding tube. Okay, circulation. So this is all about fluid balance. Okay, suctioning, so whether it be they have excessive salivation, maybe they were born with meconium aspiration syndrome, whatever the case may be, we have the ability to keep the airway clear. So for your normal newborns, remember we have the bulb syringe, but then we also have other suctioning equipment as well. Okay. Positioning. So the idea is we want to position babies so that their lungs have a better opportunity to expand. So in the cases of our preterm premature babies, we actually do like to lay them on their stomach with, of course, monitors so we can tell if something's going on. And no, we would not recommend this at home. But laying them on their stomach allows those lungs a chance to really expand, and it decreases the work of breathing. Okay, stimulation. So especially your preterm babies do not tolerate stimulation well. The more you stimulate a baby, then the more their work of breathing will increase. So for nurses and doctors, this is about clustering our care, but it may also be teaching the parents how to properly stimulate, how to avoid certain stimulation. All right, so our first issue that we have is meconium aspiration syndrome. All right, so when your baby has asphyxia in utero, then this causes our intestinal peristalsis to kick in, and the anal sphincter will relax. So this allows for the release of meconium into the amniotic fluid, which can then be aspirated in utero or during the infant's first breaths as it is born. Okay? So we care about this because meconium in the lungs causes mechanical obstruction of the airways, chemical pneumonitis, vasoconstriction of pulmonary vessels, and it actually will inactivate that natural surfactant that they need to keep the alveoli open. Okay, to care for these babies, we're going to use some tracheal suctioning. If you look at the very bottom, those are called meconium aspirators. They do hook up to normal suctioning, but they're thicker and they're larger in diameter to pull out the meconium all the way from the trachea. Okay, our baby may have some umbilical, arterial, and venous lines. Okay, so you can see that lines taped into the umbilical cord. Okay, high levels of oxygen, exogenous surfactant, so in other words, that man-made surfactant that we could administer after birth through the ET tube. Okay, and definitely some prophylactic antibiotics. Okay, now we want to assess for signs of distress and complications. Okay, now you will know in the delivery room if there has been meconium, one for the way the baby looks, so you'll see this yellowish, greenish skin and nails. Okay, you'll experience a very strong foul odor as well. Okay, now these babies are going to show distress like pallor or cyanosis, apnea, slow heartbeat, RDS, a barrel-shaped chest, decreased air movement, and rales or rhonchi. All right, talking about our SGA and our IUGR babies. So the SGA babies are below the 10th percentile in birth weight. Okay, they have a fetal undergrowth where the growth rate is normal or slow. Okay, causes of being SGA are inadequate nutrient supply, intrauterine infection, or even a small-sized mom. For IUGR, they are also below the 10th percentile in weight. However, their growth is at a restricted rate in utero. Okay, causes here are impaired placental perfusion, cord anomalies, and placental abnormalities. Okay, now as far as respiratory is concerned, both your SGA and IUGR babies are at risk for fetal hypoxia and meconium aspiration syndrome. Our post-term baby is any baby that's born after 42 weeks. Okay, so remember that in a post-term baby, your problems are related to the degeneration of the placenta. Okay, so that placenta is a living organism and it only works well for so long. And eventually the function starts to decline. Okay, so as the placenta is degenerating, then they start to experience a decrease in oxygenation and nutrients. Okay, your post-term babies are very much at risk of meconium aspiration syndrome. Here it's because there's a lack of oxygen because it's not coming through our poor functioning placenta that's causing the infant's anus to relax and releasing the meconium in the fluid. And then, of course, baby inhales it to the lungs. Okay? Post-term babies are also at risk for respiratory distress syndrome. Your preterm babies are any babies born before the 37 weeks. Now, all of their problems are related to the immaturity of the body's systems. Okay, so more than likely they have inadequate surfactant production. Okay, the muscular coat of the pulmonary blood vessels is not completely developed. So for them, their respiratory problems are going to be apnea of prematurity, okay, and respiratory distress syndrome. All right, so some of the medications we can give. We have betamethasone, which is a corticosteroid. We administer this to the mother when she is going to have a preterm baby. Okay, birth is imminent, and we want to try to mature baby's lungs. So we're going to give 12 milligrams IM for 2 doses, 24 hours apart if possible. Okay, it stimulates the fetal lung maturity by promoting the release of enzymes that induce production or the release of lung surfactant. All right, so we're using it to prevent or reduce respiratory distress for fetuses between 24 and 34 weeks. However, if your mom has diabetes or hypertension, it is a corticosteroid, so it could worsen their condition. Okay, like I said, we are giving it IM, so we will actually want to give it either ventral gluteal or vastus lateralis, okay, into a deep muscle. Okay, and we may want to keep up with mom's blood sugars depending on if she has any issues. All right, then we have our surfactant replacement. So what happens here is it reduces the surface tension of fluids that line the alveoli and respiratory passages, resulting in a uniform expansion and maintenance of lung expansion at low intra-alveolar pressure. All right, so what we do is once our baby is born, we can give surfactant at any time that we think that it needs to be done. All right, it's given by your respiratory therapist. What they do is they will actually insert an endotracheal tube just for administration, okay, unless your baby is already intubated. Okay, but what we're going to do is once the tube is in, we're going to put the medication down the tube, and then we slowly roll the baby to one side, and we let it sit for a few seconds, and then we slowly roll the baby to the other side. And the idea is that the medication is coating all parts of the alveoli. Okay, so we may use this to prevent or treat RDS in our preterm infants. Okay, now there are some potential adverse effects, although we don't see them very often. But your baby could experience oxygen desaturation, transient bradycardia, blood pressure alterations, and drug reflux. All right, so looking at the x-rays on this slide, the first x-ray was taken before surfactant was administered. You can see that the lungs look quite dense and white, okay, so the whiteness, due to the collapse of the alveoli. The amount of air in the lungs, which would be indicated by a darker black color, is very small. The second x-ray is taken after the administration of surfactant. You can see now that the lungs appear darker because now they contain more air, okay? Because we were able to expand those alveoli. Okay, our last condition is actually a condition that we see in preterm infants who have required mechanical ventilation. Okay, this is a chronic long-term condition. All right, respiratory-wise, it's caused by pulmonary immaturity, surfactant deficiency, lung injury and stretch, barotrauma, inflammation caused by oxygen exposure. Okay, our signs are going to be tachypnea, retractions, nasal flaring, increased work of breathing, and activity intolerance. Okay, so things like feeding or being handled. Okay, these babies may have an increased need in their may have an increased need in the ventilator settings, okay, or they may have the inability to be weaned off the ventilator. Our treatment is going to be oxygen therapy, nutrition, fluid restriction, and medications such as diuretics, corticosteroids, or even bronchodilators. And the whole key to bronchopulmonary dysplasia is prevention. Right, so right now we do have reduced rates of this condition because of the increased use of maternal steroids in labor and delivery before the baby is born. Okay, other things that have helped reduce and prevent are the prophylactic surfactant given after they're born, avoiding the use of mechanical ventilation when possible. Okay, and then of course we always want to prevent preterm birth and respiratory distress syndrome. The prognosis of this condition depends on the degree of pulmonary dysfunction. If they are able to come off the ventilator, then they can have oxygen at home. Okay? So pulmonary function may normalize, at least some of the ways, but small airway abnormalities may persist. Okay? Respiratory infection is the leading cause of death for these kids once they're discharged home.